Hi again, Dr. Klemp.
Hi, Stuart.
This is going to be a great session. It's called Mobilize. We're pulling this from empowering and mobilizing our patient navigation workforce. And you and I talked briefly about this on Friday, really having a better understanding of pay equity, of certification, training, how public policy can inform strengthening this workforce moving forward. So we're going to hear from public policy experts, a great interview coming right up in a sec with the New York Times. We will hear what Texas is doing. Texas has been at the forefront of community health worker certification for the past 20 years. We'll hear from a University of Texas Health expert to talk about what they've learned and what they could do a better job at, and how we in New York State and other states can replicate some of this good work. So we're in for a good hour, I think it is, hour and 15 minutes. But I first want to start by introducing our audience to Katie Engelhardt and Kim Rockwood. I watched, hi guys. I watched an interview that Katie had done with Kim on the New York Times in May. And I was immediately watched it because the headline was so grabbing. It was these people look after our most vulnerable populations, and yet their average pay is $16,200 a year. Are we okay with that? And of course I thought, no, I'm not. And yet we hear these stories across the United States, and we hear them a lot with our community health workers. So I wanted to introduce you to Katie and to Kim. We will replay the Times video that I saw, and then I'll turn it over to you both so that, Katie, you can update us with Kim on what's happened since that video ran on the Times, and then Dr. Klemp and I will have some questions. Let me just formally introduce you, though, first. Katie Engelhardt is a reporter and documentary film producer who has worked as a correspondent for NBC News, and whose writing has appeared in the New York Times, The Guardian, The Atlantic, and California Sunday. Her first book, The Inevitable: Dispatches on the Right to Die, will be published in 2021. And I'll just add in that Katie's a Canadian like I am, so I was immediately drawn to her, and she's speaking with us today from her cottage in Northern Ontario, and I think we're all very jealous. And Kim Rockwood, oh my gosh, you've been working in healthcare since 1984, and you became a certified nursing assistant in 1987. And since that time, you've become a MAP certified, restorative aid certified assistant, and you've been trained in nonviolent crisis intervention and in supportive care for Alzheimer's. You're a remarkable individual, Kim, and I can't wait for our audience to get to know you a little bit more right after we play this video.
I mostly care for people in their homes, people like parents, grandparents.
This is Nancy. This is my sweetheart.
The most vulnerable population of our society, people who need help going to the bathroom, eating, taking the medications.
This is for your bones. This is for your pain.
Brendan is paralyzed from the neck down. We do everything for him. All right, so I gotta lift you up.
Yep.
All right. I work 7 days a week, but I love my job. I wouldn't do anything else. I've worked for over 30 years doing this, and I make just over $15 an hour. I live in Massachusetts, and my salary is actually one of the highest in the country. 18% of us live below the poverty line. Nationally, we make just over $16,200 a year. And even though I work in healthcare, I cannot afford health insurance. I avoid going to the doctors. I have medical bills I haven't paid. My now tattoo is, we're all in this together, and it is, the world has a heart. Since COVID, the federal government was giving out more than $100 billion of emergency money to hospitals, nursing homes, long-term care facilities. That's great, but most of the money isn't going to people like me. I'm not a materialistic person, and I'm not asking to make $1 million. I don't mind doing hard work, but I need to make a living. I need to be able to pay my bills, especially now with coronavirus. Most home givers aren't receiving hazard pay. I've had to pay for a lot of their PPE out of my own pocket. If we are essential workers, we need to be treated like essential workers.
I know, right?
If I were to go on unemployment and stop working, I would make about the same amount of money, if not more, and then there's not going to be anybody to take care of these people, and that's just crazy. It's a very broken system. These patients are sick and they need to be cared for.
This is every innocent person's nightmare.
Last Tuesday, Nancy fell. She basically sat on the floor until she was found. I would hate to have her end up in a nursing home or a long-term care facility, but that's what's going to happen if she doesn't receive the care. I give her a quality of life that she deserves, and I don't want her to lose that. So that's why I do what I do. If she falls, she loses all of that. I'm sorry.
I love you. Yeah, don't cry. You're gonna make me cry. Come on.
It doesn't have to be like this. The federal government and the Department of Health and Human Services must require some of the money that is going out for relief to go to the frontline caregivers. States could also use the Medicaid to increase our pay. Some states increased wages for all health workers, including home caregivers. Arkansas is doing it now. Arkansas did prove that that is possible. Even a few dollars more an hour would change our lives and make the healthcare system more sustainable and safer for our patients. But when this is all over in the post-COVID world, the money shouldn't get taken away. Caregivers will still be needed. We should be paid a living wage. We need help. And then when I get old, you can take care of me, right?
Well,
This is what I've always done. This is what I'll always do. I'm a caregiver.
Hi there.
Hi.
Great. Well, Kim, thanks for joining me. I still find that piece very moving, and I'd like to talk a little bit about how things are going for you now that we're a few months on. But first, I thought it would be useful to just explain sort of how we got to know each other. So I was working on a piece for the New York Times, and our idea was to find frontline workers, find essential workers, and give them the ability and technical tools to author their own op-ed, to make their own case for what needed to be done in response to coronavirus. And I guess I started thinking about how we defined frontline workers. And Kim and I, we've talked about this, but it became pretty clear that, you know, while a lot of attention was rightly on the acute needs of COVID patients, there wasn't a whole lot of thought going to post-acute care, to considering where these patients would go and how they'd be cared for after they got better. And this was even in April and May, as we were hearing warnings from Italy that home care is going to be the next frontier of all of this. And as I did more research, it became very clear that the home care industry was already in crisis. There was an enormous shortage of home care workers. A lot of workers didn't have the training and support they needed, underpaid, not protected, uninsured, without paid sick leave. All these things we now realize are really detrimental to the health of patients. And I think, the fact that this is work that's done largely by women, often women of color, immigrant workers, hasn't escaped anyone who's been paying attention. And what coronavirus really showed us is that the health of caregiver population is closely tied to the health of the patient population. And I think that Kim, when we connected, really saw that and really had ideas for how the situation could be improved. So Kim, it would be useful just to know, I guess, to start, how things have been going for you since we last spoke, since this video was made.
I'm still working 7 days a week. I did move out of COVID-19 facility, and I'm working in a long-term care facility on top of working with Nancy and Brendan. I have a hospice couple that are living at home, and I've lost 2 people who worked for me with Nancy. Her needs were more than they could handle, so I've picked up more hours with her. Pretty much the same thing. Nothing's really changed.
Yeah. So it sounds like, I mean, even before coronavirus, we knew that turnover was a huge problem. A lot of healthcare agencies in Massachusetts, even in Massachusetts, which has, some of the highest rates in the country, if not the highest, some home care agencies were finding a turnover rate of nearly 100% every year. And when I spoke with someone from the home care industry, he said to me, unfortunately, our main competitors here are Burger King, are McDonald's, because those jobs sometimes pay better. They sometimes offer, more in the way of benefits or support. There's room to advance. There's room to, graduate to higher pay scales, and you're far more likely to get injured. Home care workers are something like 3 or 4 times as likely to be injured on the job as other workers. And so, Kim, I'm curious how you've seen that quick turnover and how you're finding it's affecting the care of your patients. And I know you've also have a specific tie to fast food and have been able to see that comparison.
I've worked with Nancy since last January, and in that time, I have been consistently working with her pretty much 7 days a week. In the fall, when I went to school, I had people working with me, including my daughter. My daughter and I are the only one that are still with her. We've gone through 5 different PCAs. To be a PCA, you don't need to be certified. You honestly don't need to be trained. And once people come in and see the actual tasks that are involved in taking care of somebody who has been hospitalized, is trying to avoid going to any sort of long-term care facility or a hospital setting, it's work, and it's complicated. It's a lot more than making breakfast or putting out medicine. And they come in with the idea, well, I'm going to make this kind of money, but it'll be easy work. And it's not easy work. And Dunkin' Donuts took my daughter, and she's now making $19 an hour as an assistant manager, and I'm making $15.94, taking care of Nancy and Brendan and my hospice couple who are dying.
Yeah.
So,
Well, I think a lot of people don't realize that, Kim is, as you've said, a certified nursing assistant, so able to work in long-term care settings like nursing homes, and also a PCA, so personal care assistant, working with people in their homes. The facilities require a certain level of training. It's not always very much, sometimes around 70 hours of training, depending on the state. But often to be a home care worker, for some reason, there's not that same criteria or same requirement of any sort of formal training. And Kim, how do you find that that's affected the care of your patients? Because obviously, you're very trained. I know Kim's also, paid to do a lot of additional certification, but you're sometimes trading off with people who are new on the job and aren't as experienced.
I've had patients call me in the middle of the night because their catheter was clamped off and never released, and the caregivers have left. I've had clients get hurt while being transferred via a mechanical device such as Hoyer's. I've had patients not given their medication that they needed on time and ended up diabetic reactions. By going into somebody's home and caring for them in a health aspect, by not being trained, you're jeopardizing their safety, you're jeopardizing their health, you're jeopardizing their well-being.
Mhm.
And you're jeopardizing the whole community of individuals living at home, because if it gets to that point where they can't be taken care of, it won't be an option to live at home. They will be mandated to go into long-term care or assisted living or whatever.
Yeah.
Because, I mean, how many lawsuits can there be, or how many injuries because of PCAs not being trained before somebody says enough's enough?
Right. Or PCAs getting hurt and not having health
Exactly.
insurance to get their own
well,
care.
I don't have health insurance still. So yeah.
Yeah. Yeah. For someone who does want training, for someone who joins the field and, they're working in home care and they want to get better and they want to improve their skills, what kind of options are available to them? Are there options to get new certifications with, some government assistance to increase that pay scale?
If you go in through like a Department of Transitional Assistance program, you can go into a certified nursing assistant program through community colleges. I know that Red Cross offers programs. However, unless you're going through a transitional program because you are getting state funding for whatever to sustain your own life, you have to pay out of pocket.
Right.
I've been certified basically through any job that I've ever been. I grab the opportunity and I take it where I go, or I pay for it. I'm $24,000 in student loan right now, finishing up my associate as an RN.
Right.
So
Right. It seems like culturally we've moved away from an institutional model. People don't want to be in the hospital longer than they need to be. It's expensive. They don't want to be in nursing homes or other kind of rehab facilities. And yet the infrastructure is still back in the old days, right? It sounds like you're still operating pretty much in the same setting that you did in the 80s.
we are, and there's right now in Massachusetts more than 36,000 people living at home independently receiving home services.
Right.
And they're not getting paid,
Yeah.
not maintaining, it's such a turnover that people end up not being able to stay. They can't live at home if nobody's taking care of them.
Dr. Klemp and I just popped up the minute we heard you talking about certification training, and we're about to move into our next segment of this session to hear from our UT Health advocate and subject matter expert. So wanted to wrap some things up with you, but Dr. Klemp, I think what we're hearing from Katie and Kim is how important it is to find the best way to sync up our training and certification and accreditation wherever you fall in the continuum. What do you think?
Right, and I also heard from Kim kind of there's not a lot of standardization or sort of it works a lot better to demonstrate your value, which you have listed off. I mean, I the empathy I have for the role that you're filling, but also the complicated nature of your patients, right? So we're talking about a lot of skills that people have. How do we demonstrate that competency? How do we make sure that there's some standards around that? And there's that need to have it be a little more universal versus all these one-offs or a lack of sort of certification. So the way that we move towards that and move towards increasing value is to put that into a story, right? And the story usually includes outcomes and metrics. That can then be taken to payers, where payers say, okay, yes, this is part of a bundle, this has to happen. So this is a very complicated picture that you've described through your experience. And it really goes to kind of the bigger society challenges we have and dealing with policy, the accreditation, the billing. Like, this is a really big and complicated issue, and that human experience, I think, just highlights the need to push this forward so we can start putting more value on a very necessary service and tool for our patients and providers and organizations.
Mm. Katie and Kim, thank you both very, very much. Any more thoughts? Before we move on to the next segment?
Kim?
No, I'm good.
You sure
Well,
are.
I think I think just as I said before, I think we're really seeing in nursing homes what happens when the lowest level of caregiver is not offered, support such as a paid sick day, the ability to stay home and to not spread infection to residents. And, all signs point to home care being the next place where we're going to see these outcomes if nothing's done.
We're tired.
Yes, the theme into the compassion, fatigue, and burnout is there, and I commend you and thank you for what you do, Kim, because you are amazing, and your resilience is amazing.
Yeah.
It sure
Right.
is. Thank you very much, Kim. Thanks so
Thanks.
much. And Katie, thank you for the piece. We sure
Thank you.
appreciate it.
Good work, Katie.
Thank you, Katie.